My name is Christopher Crane. I'm the gastrointestinal section leader in the Department of Radiation Oncology at Memorial Sloan Kettering. Definitive chemoradiation is the standard of care for patients who present with localized anal cancer. Surgery is used for salvage. This was an approach that was born out of a neoadjuvant strategy to improve outcomes in patients going on to have APR by Norman Nigro. Once it was seen that patients had a complete response, almost all the time, surgery was then used only for salvage. And the squamous cell carcinoma of the anal canal is intrinsically more sensitive than other solid tumors and remains locoregionally confined. The advantage actually of using chemoradiation, however, over abdominal peritoneal resection as a primary treatment, goes beyond just that the colostomy-free survival advantage that most people think about, but chemoradiation actually treats areas that would not be addressed surgically. So the nodal areas in the pelvic sidewall, so-called non-TME nodes, in the inguinal area and external iliac areas are all areas that are not addressed with total mesorectal excision. So the outcomes would, even if their APR was considered a competing treatment, the outcomes would be better with chemoradiation because it addresses all of the regional nodes. So the dosing for radiation is based on the size of the tumor, from T1 to T4. T1s, we get 50 gray in standard fractionation and 2 gray per fraction. For T2s, we get 54 gray and 27 fractions. For T3s and T4s, we get 58 gray in 29 fractions. We don't go over 2 gray per fraction to the primary because it causes too much acute pain in the anal canal. The microscopic doses that are given to the regional nodes are roughly a bioequivalent of 45 gray, which is really a little more than we need. Going back to the 2 and 3D era, 30.6 gray in 17 fractions was an effective microscopic dose with over 95% disease control. However, in that era, all of the data from that era included patients who were treated with 2 different microscopic doses, and the other low pelvis received 45 gray and 25 fractions. So current IMRT regimens, whether it's given sequentially or whether it's given with a simultaneous integrated boost, should include roughly a bioequivalent dose of 45 gray for microscopic dose and the doses that I mentioned for the gross tumor. When we use simultaneous integrated boost, we give a slightly higher dose when we give for patients with higher T stages because the dose per fraction is lower. We give concurrent chemotherapy, and the reason for that is that not that we would necessarily be unable to control the disease with higher doses, but the combination of moderate doses of radiation with radiosensitizing chemotherapy is equivalent to doses that would be of radiation that would be intolerable for the anal canal. So the dose limiting structures in the pelvis are the anal canal and the small intestine. The anal canal tolerates doses below 60 gray very well without any ulceration or risk of stricture. However, doses higher than 60 gray would sometimes be intolerable and would lead to complications that may require an APR. So there are plenty of older data showing that radiation alone is an extremely effective treatment for especially early stage anal cancers. But the combined chemotherapy and radiation treatment is as effective as higher doses of radiation and is better tolerated long term.